All right, so tonight's program is called The Compass to MS Care. This is Reaching Rural America and Underserved Communities. We've been doing this now for quite some time. We started this program series before the pandemic even began, and we have been doing this for a few years now in rural America and underserved communities for obvious reasons. So for those that don't know, well, my name is Stuart Schlossman, and you probably do already know that I'm president and founder of MS Views and News, and I am also an MS patient. And tonight, our supporters for tonight's program, we have Bristol-Myers Squibb, we have Biogen, Sanofi, Genentech, Novartis, and EMD Serono. And so we all want to always give them a virtual round of applause. Thank you. Yay! Here we go. All right, tonight's program. Tonight we're going to have Dr. Emily Reiser, all right? And Dr. Reiser is going to be speaking about the access to care. She's also going to be speaking about MRI, effective ways to communicate with your healthcare team, and a little bit on shared decision making, right? She's going to be speaking, Dr. Reiser is going to be speaking for about 25 minutes, and then we're going to get into Q&A. So Dr. Reiser is a very sweet country gal, and she's from the Tanner Center of Multiple Sclerosis in Birmingham, Alabama. And I'm not going to say any more about anything other than let the doctor speak. And then after about 25 minutes, I will come back online to do the Q&A. Okay? So Dr. Reiser, have a good time.
Thank you, Stu. I just want to thank MS News and Views for inviting me to come out this evening, particularly with the time change. I know it's tough for a lot of you. It's kind of dark, but we appreciate you being here with us. And we always love the opportunity to talk about MS care, not only, in your community, but in rural communities. So tonight, our topic is Compass to MS care. And what we're going to look at from an objective perspective is we're going to follow the compass. And looking east, we're going to talk about accessing the care you need while managing your multiple sclerosis. Looking south, we're going to learn more about MRI updates using MRIs, particularly now as biomarkers, which is pretty fascinating. And as we go west, we're going to talk about effective ways to communicate with your healthcare team. And finally, as the compass looks due north, we're going to talk about a very, very important decision that's been around for a long time, but it's just critical as we go forward in caring for patients with chronic illness, and that's making shared decisions about your MS healthcare plan. So we need to remind ourselves that MS affects approximately 1 million individuals in the United States. We used to think it was 350,000, but it's now really recognized that approximately 1 million people in the United States of America suffer from multiple sclerosis. And the fascinating thing to me as someone who lives in Alabama is most specialized MS centers are in urban areas. And the barrier for MS care in the rural areas is obviously obvious because, you're left with not too many providers in your particular communities. And so what we've learned, particularly through the pandemic, is that telehealth is going to be the solution for everyone living with multiple sclerosis, whether you're in an urban area or in a rural community. So telehealth is becoming our key solution for accessing MS care. And I can tell you now, even in my practice, our practice is becoming a hybrid practice of both, in-person care as well as telehealth. And this gives the opportunity for the MS patient and their caregiver, to connect with their MS doctor and that MS team, that specialized multidisciplinary team. Because a lot of times you can't expect the patient and the caregiver and everybody to synchronize their schedules. So this way, the telehealth gives everyone that opportunity to come together to problem solve relative to the ongoing care that is necessary for managing multiple sclerosis. So the telehealth platform solutions are as follows. These are just 3 that I've, been using, and we can kind of talk briefly about them. One is the electronic medical record. You'll hear people talk about EMR, but these electronic medical records have become very sophisticated. They have embedded in the EMR these systems called Helo and what have you, where you can directly see and talk to your providers and your team, just like we're doing here tonight, which is pretty extraordinary. But you have to have internet access, and you have to have an email address, and you have to be engaged with the system. So it's something that you have to set up when you go to the provider's office so that they can then have this capability for you to reach out through the EMR and the Helo. The second is a platform called Doximity, and this is a free platform that providers can download on their telephones. And I love this Doximity because there's a digital divide in the South, and not everybody has internet access. So if you just have a cell phone, this Doximity platform will allow a physician, a physical therapist, whomever, to be able to call you directly on your phone, and just through a text message, you can then connect with the doctor directly. So I like Doximity a lot. Other things that simply have to be used sometimes when there's no access is FaceTime through iPhone or Android. So those are other platform solutions. So telehealth does offer an array of services. I think patients kind of feel like sometimes it's just that link to the doctor, but not only can medical consultations be provided through telehealth, you can also access care to your physical therapist, your occupational therapist, speech pathology, counseling, you name it, because we are offering all these services through our clinic, and many of these services are now being delivered through telehealth. Okay, so that was pretty much our first objective, which was kind of looking east. And now as we begin to look south, we're going to focus a little bit on magnetic resonance imaging. And this has been around since the 80s. But MRI stands for magnetic resonance imaging. And I always repeat that because sometimes people get this confused with CAT scan. This has nothing to do with radiation. This has everything to do with magnetic resonance. And it's a very unique principle. And basically, what happens is you can create energy that can be captured from spinning protons. And when I say protons, that's important because 90% of our body is made of water, and the predominant element in the water is the proton. So if you go into a magnetic field, you can spin these protons, and then scientifically, you can relax that spin and reconstruct images that can show both gray matter and white matter in the central nervous system, which is extraordinary. And it not only can image the brain, but the MRI can also image the spinal cord and the optic pathways, because those are the three areas that we're very concerned about when we're not only diagnosing MS, but as we manage MS going forward. So these are what we call the common MRI sequences. And a lot of times when you're seeing your doctor, they may be throwing out all these fancy terms and you're not quite sure what they mean. But the sequences have everything to do with something called a relaxation time, when the protons are no longer spinning and they're in a relaxed state. And these sequences are called T1, T2, T1 with contrast, something called diffusion, and then something called flare, F-L-A-I-R, which is actually a fancy T2. So when you hear this terminology, these are the common sequences that we're talking about when you're laying in that tube and hearing all those noises. This is what is being reconstructed scientifically as those protons come out of a rapid spin phase and begin to relax. So the role of each of the MRI sequences is very important because T2 shows us everything that we need to know about whether or not there are MS plaques. And when I say plaques, I also want to use the term scars or lesions because a lot of people are not sure if there's any difference between all of that, but actually that's all the same. So when the doctor is reviewing your MRI, the questions you may ask is, well, on my T2, how many lesions were there? The T2 is the best sequence for really capturing the numbers of lesions in the CNS in the white matter. Now the T1 is a little different because the T1 sequence helps us to understand if the lesions or the scars or the plaques have undergone secondary degeneration. So we think of MS as being an inflammatory condition. But we also have to understand that it's a degenerative condition, and that will show up as very dark spots on the T1 sequence referred to as black holes. And finally, the T1 contrast is the sequence where the technician will start an IV and inject a contrast material into your vein. That material will then circulate all through the intracerebral blood vessels, and it can be captured as a contrast agent that looks white against a dark background of T1. And this will give us the ability to show if the MS plaques, scars, lesions, are active or not. So T2 is the plaques, T1 is the black holes, the secondary axonal degeneration, and T1 with contrast is a sequence that shows us active lesions. So these are the classic T2 flare, which I told you is a fancy T2 sequence, the flare, fluid attenuated inversion recovery. That's a fancy T2. It's going to show us the plaques, the lesions, the scars in multiple sclerosis. And this particular view would be what we call sagittal. So it would be as if I turned my head this way. It's a view from one ear to the other ear. And this would be precisely in the middle. And these plaques, as you see, kind of stand up. They are perpendicular to the surface of something called the corpus callosum, which is right above the ventricle. And these lesions stand up perpendicular and longitudinal. And the word that we use is periventricular. These are periventricular stand-up lesions that look very classic and very pathognomonic of the condition that we now call multiple sclerosis. And when we drill down a little bit more on these plaques, this would be an axial. So we've gone from sagittal to axial. This is T2 flare. And what we see here is these perpendicular, periventricular, longitudinal, classic MS lesions that we now call Dawson's, D-A-W-S-O-N's fingers. And this was named by a scientist that discovered this long before MRIs. This was just looking at pathology. And these are the characteristic lesions that we see in MS. And this is so important because MS is a condition that causes inflammation around little bitty veins. And these little bitty veins are coming out around the ventricular system. Therefore, these longitudinal perpendicular plaques are always going to have that particular appearance, the Dawson finger appearance, and it speaks to the pathology of multiple sclerosis. Now, the classic T1 lesion, with or without contrast, is going to look something like this. On the left, you see that there are dark lesions, but then you see that there are white lesions, and those white, bright lesions are actually the contrast agent that has leaked across the blood-brain barrier from the blood vessel. You injected the contrast into the blood vessel, and that white contrast material has gone into the brain. So that would denote on the left that those are active MS plaques. On the right, however, you see an axial T1, and you just see dark lesions. And those would be MS plaques that have secondarily broken down into secondary degeneration, or what we refer to as the black holes. Now, there's been a new update for MRI recommendations that just came online this year, 2021. A paper was published in the Lancet back in August. And so now there's some new things that we need to think about relative to diagnostic MRI and maintenance or surveillance MRIs. And these are the following things that I took away from the paper that I want you to know tonight. And that's number one, when diagnosing MS, a brain and a cervical spinal cord MRI should always be ordered at the outset, and that should be done with contrast. The second important recommendation is that once a new treatment for MS has been started, once the diagnosis has been established, that treatment should be monitored in approximately 3, no longer than 6 months after the initiation of that treatment with a follow-up MRI, and then subsequent MRIs need to be done every year thereafter. The third consideration is that once the patient with MS begins to plateau and stabilize to some degree, the new recommendation is no contrast agent should be given to patients when conducting surveillance MRIs on an annual basis. And the reason for this is the We now know that the gadolinium, the contrast agent, can sometimes accumulate in the brain, in the back part of the brain, the dentate nucleus of the cerebellum, in the basal ganglia. And we don't clearly know what that might cause over time. And when you look at the cohort of patients with multiple sclerosis, they're having so many MRIs. The new 2021 recommendation from North American, European, and consortium says that we really need to be very judicious about administering contrast agents. So the new recommendation is that you'll see your neurologist ordering your annual MRI, probably without contrast. And finally, it's now known that it's safe to conduct MRI imaging in children, because children do have multiple sclerosis, pregnancy, as well as in postpartum women. So future biomarkers. This is still part of our, our south axis on the compass. I'm excited to tell you that there are 4 things that are becoming really exciting right now in the research field, but they probably will become more routine in our practice over the next couple of years. And these are the 4 focuses of biomarkers in imaging, and that's the central vein sign, the paramagnetic rings, cortical plaques, and volumetric MRI. And so I'm just going to briefly talk about each of these categories. The central vein sign, remember I told you when you look at the Dawson finger, which are the lesions that are kind of coming off of the ventricular system, which is inflammation around a very small vein. Well, as it turns out, when you run a specific MRI sequence, something called a T2 star or a susceptibility image, we can actually see the little vein in the middle of the circle of inflammation. And this is becoming very pathognomonic for multiple sclerosis. And this is very important because a lot of people come to us with, quote, abnormal MRIs, white matter changes on the MRI. And if we can see the central vein sign, we can begin to understand that this particular individual actually has MS and doesn't have microvascular disease, which is something related to hypertension, diabetes, high cholesterol, smoking, migraine, headaches, etc. So this is a very, very up-and-coming pathognomonic MRI metric. The second is this notion of what we call paramagnetic rings, and you're getting into a lot of fancy stuff, but a paramagnetic ring is a fascinating concept because what we're seeing is on certain sequences, we're seeing chronic MS plaques that we used to just think, well, that's just old and chronic. But when we start seeing this little haze around this darker area, what we now know is that that's not just a chronic plaque. That's a plaque that's actually undergoing chronic inflammation, which is critical when we think about, an individual being on a certain treatment, knowing that maybe that treatment is not effective enough when the appearance of these paramagnetic rings shows up on surveillance imaging. Cortical plaques. This is another fascinating biomarker, and a famous neurologist at Mayo Clinic, Claudia Lucanetti, had done all the original work describing cortical plaques in multiple sclerosis. And we used to think MS as just being a white matter condition, inflammation of the white matter of the central nervous system. But now what we know is that MS also affects the cortex, which is the ribbon around the white matter. And these tiny little bitty plaques can actually be in the cortical gray matter. And we now know that these little plaques might be a biomarker early in the course of disease that tells us that there's going to be a more significant degree of progression. So it might really, show the treating neurologist working with the patient with MS that they might want to opt for more aggressive treatment early in the course of the disease. And finally, volumetric imaging. That's basically MRI capabilities that show us the actual amount of plaque in the brain or the actual amount of degeneration in the brain, hence the word volume. And when you look at the pink and the blue and the green, what you're seeing is these are deep subcortical gray matter areas in the central nervous system. And now the scientists have a way to measure how that changes over time. And several studies have shown that there is this subtle degeneration that can occur even in the absence of relapses or symptoms. And this is going to become very important as we go forward in terms of helping us to assess the efficacy of certain drugs for treating MS. And I think we'll begin to see volumetric MRIs as maybe an outcome measure in a lot of clinical trial data. Okay, so we've completed our voyage to the south on our compass wheel, and now we're kind of headed west. And I think that this is a very important topic, and I'm always glad that Stu incorporates this into our discussions. And that's, quote, effective ways to communicate with your healthcare team, whether that be the nurse, the doctor, your infusion nurse, the medical assistant. I mean, anybody that's on your healthcare team, you've got to have effective ways to feel comfortable in communicating with them. So I think my best advice, when you think about your time, face-to-face with your providers and your team, knowing that it can be somewhat limited, always be prepared. So keep a journal, write down your list, be thinking about a timeline. If something weird happens, like if you get stiff or you kind of have some strange, whatever that happens, get your caregiver to video that, because a lot of times if I can see it, I really have a better understanding of kind of what you're trying to describe. So these are just a few little tricks, but also try to be concise and specific, because when patients are coming to see their healthcare provider who specializes in MS and in multiple sclerosis, we're trying to determine, number one, are the symptoms that you are telling us, does that represent that you're having breakthrough disease? Or do those symptoms, mainly just mean something entirely, something totally different, unrelated to MS? I can't tell you how many people I've seen over the years that have had acute MIs thinking that they're having an MS hug. So be very specific in what you're reporting to your doctors, and always include the caregivers. Caregivers, we love you. We want you to come to the meetings. We want you to be on the Zoom calls, and we really want your input, because that's going to make a huge difference in the outcome. So these are our communication solutions. Basically routine clinic visits. If you're going to come to the clinics, there's still masking that's required in a lot of clinics, televisits, telephone visits, EMR visits, patient portal visits. But if you don't have access to a phone or you don't have internet, write a letter. I still get a lot of letters, and they can be very impactful in terms of helping me or your provider to understand what's going on with you. All right, so finally we're heading north, which I think is probably the most important part of this conversation, which is shared decision making about your MS care. A concept that came online back in the 70s, but it really kind of gained some momentum during the Affordable Care Act. But we really need to start focusing on this concept. So shared decision making has everything to do with the healthcare provider and you, the patient, working together to make the best healthcare decision for you. This is not about the doctor. This is about you and your outcome. And this outcome needs to be based on evidence-based medicine. So those are clinical trials, publications, manuscripts. And it also has something to do with the particular healthcare provider that you're seeing. They have to have some degree of knowledge and expertise in knowing what's going on with you so that they can convey the best evidence. And finally, everything needs to be focused on the patient and the caregiver values and their preferences. So I'll show you a diagram of what this should look like. So this is the shared decision-making paradigm. And if you look over here, clinicians practice in green, and you look at disease in yellow. Well, historically, 30 years ago, 40 years ago, I'm old enough, I've been there. That's all that really went on. It was very authoritarian. Patient would come to see the doctor. You've got this, you do this. Do as I say, not as I do, we always laugh about. But that's just the way it used to be. But in the shared decision-making paradigm, this has everything to do with kind of the light blue, the patient well-being, the dark blue, the family well-being, the community, the geography, the demographics, the healthcare system that they're in, whether it's Medicare, commercial, treatment options, but everything needs to be driven by clinical data and evidence-based medicine. And so I'll leave you with this. The Compass to MS Care success strategy looks like this. It's a good game of Scrabble where the doctor and the patient form a team. You come together, share decision-making, and if you can do this and make this happen, in your area, whether that's rural, urban, or some hybrid setting, this is the secret to success. So with that, I'm going to wind it down, take a few questions, and I appreciate everybody being online tonight. Thank you.
Great. Thank you very much for going through this. And
You're
it was
welcome.
very detailed, and fortunately not a tremendous amount of time, so I do thank you for this, all right? All right, so, we have some questions that people have brought up about, like even MRI, all right? They want to know, why is it that sometimes they hear that it's being used as a biomarker and other times not? Can you define that at all?
The traditional sequences are part of routine care. The biomarkers are still in the research phase.
Okay, but for like if a patient from when they're first diagnosed, are you as a neurologist keeping track of those MRIs to see where the worsening might be taking place, if at all?
Absolutely. We always do subsequent MRIs at time points after treatment and on an annual basis for surveillance. And we're always looking at the numbers of lesions, whether they're enlarging, whether there's active lesions, black holes, everything we just discussed. So the answer is yes.
Okay, thank you for that. What about you said about the contrast no longer being needed?
That's correct. The FDA has looked at this, and we now know that contrast does accumulate in certain parts of the brain. We don't know what the consequence of this should be, but based on these recent recommendations that have come out of this Lancet paper, they're recommending no contrast for surveillance MRIs. So those are those MRIs that patients are getting every year.
Okay, thank you. And can you tell us what was happening with that concentrated contrast?
So what was happening is and you can actually see this on subsequent MRIs, you can see little light spots down in the cerebellum and down in the basal ganglia, and they shouldn't be there. They should clear out after a determined period of time. Like if you have contrast, it should go out that day. 6 months from now, you shouldn't be seeing it in the brain. And the problem with MS is patients with MS have to have so many MRIs. It's not like if you slip a disc and you get one MRI and the surgeon operates on you. This is like an ongoing lifetime surveillance tool. So the new recommendations are no gadolinium for surveillance MRIs.
So what is the downside of having all that contrast buildup?
FDA doesn't know yet, and we don't know specifically, so I would like to come back in time and talk to you about that. I think this is an evolving story, and the fact that the committee came out so strongly against this, there's something to this.
Okay, thank you for that. What about tell us about the 3D images that people are now getting in, like your higher, what do you call it, the old MRI was 1.5, and then we built that up and we went to 3.0. Is that where the 3D images are most effective?
Yes. Okay. So you can run some of these images on 1.5 and 3D. And if you go to the consensus paper, like I said, it's in Lancet in August. The recommendation now is 1.5 or 3, not 7T, which is strictly research. But the T2 images, particularly the flare and the T1, can now be run with a 3D sequence, which gives us better specificity for seeing plaques.
Okay, thank you. We've heard that there are certain places where you could do stand-up MRI versus laying down. What is the benefit or disadvantage of having a stand-up MRI?
The stand-up MRI, unfortunately, is not advantageous for a patient with multiple sclerosis because the field strength is usually 1 Tesla or less. Mm-hmm. And like I said, the consensus paper is the field strength of the magnet should be 1.5 to 3T. So if a patient is claustrophobic, they simply need to have the doctor order the MRI at the hospital under conscious sedation so that they can get at least a 1.5 Tesla MRI.
Okay, thank you. Thank you.
Yep.
There was a doctor that recently spoke and said that the MRIs, the way that they're being done right now, is totally wrong. That, unless the patient is using the same machine with the same radiologist, with the same everything, all the instrumentation has got to be exactly the same all the time, or it really is not helping with the continued success of watching what's going on with the patient. What do you say about that?
Okay, I think if you live in an urban area, I think that that's probably the best advice. Same magnet, same sequences, same run. But for the patient that lives in a rural community, that's not always a possibility. Sometimes
Okay.
they don't even have access to MRI imaging. So you have to just apply what you can, but the answer is yes. If that's feasible, it's always the best. And if you go back to that paper, they will tell you precisely how each of these runs for these MRI images should look like.
Gotcha. Thank you for that. All right,
Yep.
Next, let's go on and talk a little bit about patient communication with the healthcare provider. What happens when a patient calls the doctor's office today and then has to call back again in a couple of days from now because it's not getting a response, and then another week goes by and still not a response? So how are we able to tell the patients that it's great for them to have good care with their doctor, or being able to be in good communication if the doctor doesn't have time to respond?
Yeah, I'll tell you one thing that's really improved that communication, Stu, is the patient portal. And of course, you have to have internet access. If you're in the digital divide and you don't have internet access, it's as you described. But I think it's important for the patient to have that contact inside the office. You've got to make that contact if you don't have internet access with that person, the medical assistant, the nurse, whoever, so that when you call, you have that relationship with them. And they're not going to blow you off, for a day or two or three or a week. But it's been a problem. But I think the patient portal is really helping to remedy that barrier. I'm going to call it a barrier because it is.
Sure. But then the doctor still has to have an X amount of time available, even to go through all the questions that are being asked by, if you're in like a more rural area like yourself, I guess you have more time to answer. But a doctor who might be seeing 30 patients a day might have a little bit more difficulty in getting, response back to everybody. Do you find that an issue?
Yeah, the portal is being answered. The portal is also being triaged by the nurses. So there's a lot of eyes on this, and I see 20 patients every day, and I manage to get to all my portal questions. And I think too, the patients are very respectful about when they send these queries. I don't get these queries at midnight. I get them throughout the day, so I'm able to get to these at the end of the day.
Okay. And what about those that are trying to reach their doctors for, to get medications or whatnot? What's the best to get, like refills? Is that something that they should be using the portal for as well?
They should use the portal for the refills. And the other really fascinating thing now is the specialty pharmacies and the pharmacies now have an electronic capability of sending direct orders to our electronic medical record on our desktop. So I have one little area that I just press, and I can see all of these electronic prescriptions that have come in from pharmacies and specialty pharmacies. With a click of a button, I can make those fills in 10 seconds, 20 seconds, 30 seconds.
That's
great. So the technology is really helping us.
Great. Thank you for that. Are all neurologists now across the country, MS neurologists, following the same protocol?
No. In terms of how they treat patients?
No, not about treating the patients. That we do know that everybody has their own way. But even though using a portal.
Oh no, I think there's still some holdouts. There's some old doctors that are just terrified of technology.
Right.
And I've been practicing for over 35 years. But let's face it, you have to, if you're going to keep up with the times, you have to embrace technology and be on the cutting edge of what is considered, scientific and up to date. And but there's some holdouts that have the old paper charts, and I think that's where the barriers, are coming in. But patients who live in rural areas still have telehealth capability of getting a doctor, in an urban area at an MS center. They can dial up and be seen by doctors far away. So, I mean, that's an option too.
Right. What about the patients that are brand new, all right, and it takes them X amount of months before they can get in to see a neurologist? What would you recommend to these people?
I find that very unacceptable. I think if a patient has had their first relapse of optic neuritis, transverse myelitis, ataxia, whatever that is, they should be seen within 2 weeks. If not, they need to get their primary care doctors to pick up the phone and call these specialists and insist that these patients be worked into the clinic. So 6 months is unacceptable.
Okay, great. I'm actually glad to hear that. So everybody that's listening, when you can't get an appointment, just get on the plane and go to Birmingham and go see Dr. Reiser, okay? Because she'll take you right away. All right.
I'll be honest, most of your MS specialists are really great about working patients in.
They're trying hard. They're trying very, very hard to get everybody in, but we still hear from those that are complaining about it. Another question about the communication, or let's go into shared decision making. How often do you hear from caregivers rather than the patient, he or herself, when it comes to trying to find out what's best for their loved one to be doing?
Yeah, fortunately, I don't know if it's just a cultural thing in the South, but the caregivers come with the patients. It's very family community oriented. So, and we always insist that we have a contact individual, on the record that we can reach out to, because sometimes patients with MS have, memory issues and other things that they suffer with. And so we always have to have that context so we can reach out and kind of see what else has been going on. So we try to utilize that too.
I don't remember anything like that ever happening.
You're in Florida.
No, people here do the same thing. I was just making a joke about the memory. All right, let's go. So going with shared decision making, do you find that it's more the doctor that's trying to push the patient into doing something, or that the patient is just as accepting what he or she and the type of treatments that they want to be on?
Well, the good news about the MS community, they are educated. They do their homework. Thank you. They keep up with, current events. They watch your programs. They're plugged into the MS Society and other nonprofits and what have you. And I've always been impressed with this population of patients. So I've never found it difficult to really work in a shared decision-making paradigm with my MS patients. Seems to be more problematic in other diagnoses.
That's quite true. That's quite true. We hear about that all the time. Now, I need to flip back onto the MRI for a minute. Sorry about that, but somebody wrote in that they want to know if they should be doing an open MRI or a closed MRI.
Closed MRI.
Thank you for that. And can you just tell them why it's better for a closed MRI?
Because the higher the magnetic field, the better the opportunity to see lesions. And if you have an open MRI, the radiologist or the neurologist might not be able to make an accurate diagnosis or change your medication if that were the case.
Okay, thank you for that. All right, next, how often should a patient be getting an MRI? And is there any side effect to getting too many MRIs in 1 year?
No, there's no side effect to getting too many MRIs as long as they're not with contrast. An MRI, magnetic resonance imaging in and of itself is not dangerous. Like I said, the new recommendations say that pregnant women and postpartum women and children can have them. So MRIs are safe. Verdict's out, okay? The consensus statement on the 2021 recommendations is if you are newly diagnosed with MS and started on an MS therapy, you should have a subsequent MRI at least at 3 months, no longer than 6 months, to determine if that particular treatment is effective. If it is, thereafter, a surveillance MRI should be done on an annual basis. So that should be every 12 months.
Okay, thank you for that. Patient wants to know what you were saying before about doximity. Can you bring that back up again, please?
Yeah. So Doximity is an app that a provider can put on their iPhone or Android. So that's not just a doctor. It can be like a physician assistant, a nurse practitioner, a physical therapist, an occupational therapist, a speech pathologist. As long as you have some kind of credentials, you can have this app on your phone. And then what I can do through this app is if you want to see me and we want to have a face-to-face communication, say you don't have internet access, but you have a phone, then I can just send you, call your phone number, it sends you a text, okay? You press that text and it connects you to me, and we can see each other, and we can talk. And
That's great.
It's quite remarkable. It's free. So they've done a really good job with this app. And during the pandemic, I would say that more providers use Doximity than Zoom, because I don't know how many of you know about Zoom. It's fine when it works, but a lot of times it's just kind of squirrely and you get cut off. And so this Doximity too is HIPAA compliant.
Great. Thank you for that. All right. What are the new findings? Persons want to know, what are the new findings that you can speak about for research opportunities with multiple sclerosis?
So
Where
what
do
are
they
the
go
new?
and look for these things?
Oh, they can go to clinicaltrials.gov. So type in clinicaltrials.gov, and they can it's all archived on the website, and they can see every trial in the country, in their area, whatever.
Okay. A few people are asking questions about MRIs, and I'll get back to that again in a minute, but just to continue on this pace for a moment, a person wants to know how they can have access, how can I access more resources?
More research? How can I access more research?
Resources.
Oh, resources. I'm sorry, it kind of got cut off. Resources, they can reach out to the National MS Society. They can reach out to the Consortium of MS Centers. They can reach out to the Multiple Sclerosis Association of America. There are plenty of resources. So I would suggest starting out at least in the Multiple Sclerosis Foundation of America would be another one. So if you just Google, they're all there. You can get resources.
They could also watch MS Views and News because we do a program a month only on resources.
Well,
How about
this
that? How about that?
This is at the
That's
top.
part of the MS Hub series. So, Doctor, so you know, we have a series called the MS Hub, and it's only about resources, okay, that are available for the patients, and that is once a month. All right, next we have how do you set up, okay, we'll go back to that in a minute. All right, next one is, are there any classes for caregivers?
That is a wonderful, wonderful question. Sometimes you'll see these things, maybe Stu, you may have one that I've not seen, and you can answer to that. But I know that the MS Society has something called the Navigator link. You would be signed up with a person like a case manager, and they have all those kind of resources to help with the caregivers.
They do with that, yes. There are many caregiver resource sites on social media. So if a person is on social media, I would recommend that you look up MS Caregiver on social media, and it'll give you your answers as to the groups that are available. But of course, those are only online. It's very hard in person, even pre-pandemic, for caregiver groups to last. I mean, they all show up day one, and then next month there's nobody there. So it's been a problem for many. All right, next. Person wants to know, they move from one area to another area, and they just want to know how they can find out about support networks in their region, in their new region.
In their new region, I would have to say that the National MS Society does a good job of connecting people regionally, geographically. So I would probably reach out there first.
Okay, good. Thank you for that. All right. Person wants to know how they find out more about information on walking.
Walking is complex. It's a very dynamic process, but I would reach out first to a physical therapist.
Okay, thank you. What about a person who's talking about what do they do for curling fingers?
Curling fingers has to do with a concept called spasticity. Again, they would want to reach out to a specialist, someone who really focuses on spasticity in their community, and usually that's going to be a PM&R physician. Physical medicine and rehabilitation, they have specialized clinics that focus on spasticity.
Okay, thank you for that. Going back to MRI, a person writes, why is contrast bad? I've heard that I get contrast on almost all my MRIs. Sorry about that. I couldn't see. It's behind a camera.
Yeah. Contrast is not bad. It's necessary. It's necessary for the diagnosis of multiple sclerosis and in certain situations where maybe there's been a relapse. It's very important to get a certain type of contrast, a macrocyclic contrast and not a linear contrast. And that's kind of the most important thing. All the centers now use the favorable macrocyclic contrast agents. The only issue is going forward, if someone has MS and they're getting surveillance MRIs on an annual basis, it's possible that this contrast agent could accumulate in the central nervous system. We don't know the impact of what that might be, but the new consensus guidelines suggest that no contrast going forward unless absolutely necessary.
Okay, and that's the next question is from somebody that's asking something similar to what you were just answering, in that if MRI with contrast is not recommended annually, how will they be able to diagnose and keep track of active scans?
Yes. So what we're saying now is if there's a new T2 lesion or an enlarging T2 lesion, that denotes disease progression.
Okay, thank you for that. Next is about how to communicate effectively with assisted living administration who doesn't seem to care at all about their residents with multiple sclerosis. So how do people living in an assisted living facility then get the type of care or the outreach with a neurology team?
That is a great question, Stu, because you know what the problem here is with the assisted living is most of the patients in assisted living are geriatric, and they're there because they have had a stroke or they suffer from Alzheimer's disease, versus an individual with multiple sclerosis who has unfortunately developed progression and they need that assistance, but they are not old like the rest of those people. And so they're kind of treated the same as patients that have all of those comorbidities, but really it's complicated. I think that the telehealth could help those individuals. They just have to bypass the administrator and just reach out directly to the team, do it from the facility.
Sure, thank you for that. All right, now getting a little bit off subject here, but still obviously about MS, is that how do you tell the difference between a muscle spasm, spasticity, or cramps?
Okay, they're all very distinct. Spasticity can be assessed clinically. It has to do with tone. A muscle cramp is something that's more intrinsic to the muscle itself, whereas spasticity is a problem with the brain, with the transmission of impulses to the muscle. And it can be assessed clinically, whereas a muscle cramp or muscle pain is actually just in the muscle itself, and it's not associated with tone at all. They're just entirely.
Is there a common treatment to use for all three, so that way a person doesn't really have to figure out what's wrong with them in the middle of the night when they're in excruciating pain?
Not necessarily, because not all spasticity medications treat pain, and not all pain medications or analgesics treat spasticity. So it's going to be incumbent upon a really astute clinician to differentiate between the two and to come up with a strategy that would be effective for the patient.
Okay, I had to take my earpiece out because as I was asking about spasticity, Siri decided to start talking to me. All right, so going on to another thing, is it easy to misdiagnose optic neuritis? I mean, what are the shortest times you've personally seen a patient to regain, you know, how do you get them to regain their vision? Does it take a long period of time, or is it something that can be, you know, short lasting?
Optic neuritis is very easy to diagnose. Painful visual loss. In multiple sclerosis, it will be one eye. If it's both eyes, It's probably not MS. It's probably NMO or MOG, MOGAD. But optic neuritis is painful visual loss, typically in one eye. We can sometimes see the inflammation at the optic nerve head. Sometimes we can't see it, but when we do an MRI, there'll be enhancement along the course of the optic nerve. We can see that. So it's pretty easy to diagnose. Most cases of optic neuritis are steroid responsive, and that visual acuity could return within 6 weeks, but in some patients, it may take longer.
Okay, thank you. And you brought up NMO, and I'm going to ask you a question about that nobody's written. So how are you, and what are the protocols now in place for differentiating a patient that might have been diagnosed with MS to now being diagnosed with NMO?
Okay, so for the audience, NMO stands for neuromyelitis optica, and we even now call it NMOSD, so neuromyelitis optica spectrum disorder. Very fascinating, aka the old DEVIC, DEVIC disease. So NMO has a specific biomarker that is positive in most cases, and it's called AQP4, aquaporin 4. So it's something that can be measured in the blood. So you just give a tube of blood, we see it. Most cases, we see this AQP4 is positive, and the treatment for NMO is entirely different than the treatment for MS. The only issue is this, Stu. About 40% of those patients were previously diagnosed as having multiple sclerosis and given MS therapies, which actually could make their condition worse.
Right, that's what I've heard. So we started doing things recently and putting out information about NMO because we know the importance of people getting correctly diagnosed and not finding that their MS is getting worse and worse and it not be MS. So yeah, we started doing this a lot recently as well. All right, just going to get down to a few remaining questions here, and that is when a person, I know the answer and I know what your answer is going to be, but a person wants to know at what age do they stop taking their medication?
That's a great question. The concept that we need to focus on is something called immunosenescence. It's a big word, senescence, aging, aging of the immune system. And what once was autoimmunity can become immunosenescence. Everything gets old. All of our vital organs get old. And it may be that there's a phase or a time where we need to de-escalate therapy, meaning we might have someone on very aggressive therapy because, we had to really get that under control. But as a person gets to be 50, 55, 60, maybe a lot of that changes. We don't have great biomarkers yet to tell us an absolute, but I would say that's an up-and-coming topic right now.
Right. Thank you for that. What about the flip side of that? A person could be 65 and have very active MS and still progressing. Is there any tail end to that, or can it just continually get worse?
No, absolutely. And some of these patients that are diagnosed later in life can have very aggressive multiple sclerosis. And one of those biomarkers, that paramagnetic ring, I think that's a very interesting biomarker for people that are older. When you think, oh, everything's okay. Well, maybe everything's not okay. Maybe there's this foci of inflammation that just keeps giving, just the gift that keeps on giving and causing problems for this patient. So I think that we have to be mindful of both the clinical and the paraclinical data, see patients at time points, 4, 6 months, and really pay close attention to the clinical course.
Okay, thank you for that. I'm out of questions. Oh, no, wait, somebody just wrote one in online, so I'm going to ask her a question, all right? What if you are not diagnosed until you are 50 and start meds like Ocrevus, and then there's a time that it becomes ineffective faster due to the later diagnosis?
Well, okay, all medications, we don't know. One shoe doesn't fit every size, okay? So, but one thing about B-cell depleters, and that's Ocrevus, it depletes B cells. It depletes your humoral immunity, so you don't make antibodies. That's a problem in a pandemic, or if you need a vaccine. So we have to be mindful of sustained B-cell depletion. And the big story with B-cell depletion is if your antibody levels go down and remain low with subsequent cycles of Ocrevus. If we begin to see that, we need to pull back and de-escalate and transition somewhere else. And there are plenty of other places that we can go for other therapeutic options.
That's great. Thank you for that. I do have to say one thing that's really, really different from tonight's program that I have not heard since February of 2020. There were no coronavirus questions tonight.
Yeah.
Isn't that amazing?
Yeah.
Zero. That's totally amazing. This is the first time we've done a program since February of 2020 because we didn't have coronavirus realistically in the United States. I mean, yeah, it was in Seattle, but everybody thought it was going to stay there, right? I want to be thankful to everybody online tonight that you did not ask anything about COVID. Okay, it really made me feel good not to see this. All right, so there is one more question though about not coronavirus. A person is writing, so good T cells with low B cells, is that okay? Is that good or what?
So good T cells and low B cells? Is that what they're saying, Stu?
Yes.
Then they're on a B cell depleter, it sounds like. That can be therapeutic. That can be therapeutic. Okay.
Yep. Yes. All right, so, okay, that's great. All right, so again, we're finished for tonight, and we're perfect because we're right on time where we wanted to be. And Dr. Reiser, I want to thank you like usual, and I cannot wait to get back to Birmingham. I have to go to that, oh my gosh, I can't remember the name of the restaurant, next to the Marriott over there on the big restaurant. I forgot the name of it. Anyway, Paris? I'll find it.
We'll find it. Is it Paris?
No, it's something with a P. I think it is with a P, but it's a French name.
Look, there's so many great restaurants here. Y'all think we're really kind of in the dark ages, but we're really quite a foodie town. People here love food.
People ask me all the time, how do you go to Birmingham? I said, it's a big area. I mean, it's not a little hole in the wall. It's a great area to go to. And you know,
UAB is becoming a really up-and-coming university. I mean, so if your kids are looking to go to college, don't rule out University of Alabama in Birmingham. It's a great school, good community.
Thank you. And I was right about the restaurant beginning with the letter P. I was just reminded by somebody else it's called Papa Dough.
Oh, Papa Dough's. Yeah, I know. Yeah, it's a good one.
Great place. I can't wait to go back there again. All right, so doctor, thank you very much for being online tonight with us, all right? Again, I can't wait to see you in Birmingham. That will be in 2022 for sure. Okay, and everybody that's online tonight, please check our website. We are now doing live programs again. So check our website, see where we are going to next, because we have a few of them still to do by the end of this year. And going into January, we're going full force. We'll hope to do 2 or 3 programs a month live, in addition to all the virtual programs we are doing and the classes that we have for yoga, Pilates, and physical therapy. So yes, we are going in with all guns. All right, we even have some support groups now in Florida. So, all right, so I look forward to seeing you all soon. And doctor, again, thank you and have a great night. It's still early for you. Go enjoy.
Yeah, thanks, Stu. Happy holidays to everybody. We'll see you next year.
Thank you. Perfect. Ciao and out of here.